This is part 2 on pain from Essentials of Pediatric Nursing by Kyle and Carmen. So, how are we going to manage pain for children? We really do, just like everything else, need to individualize interventions. So consider what the pain level is, what the child's developmental level is, their temperament. Are they somebody who just overreacts to everything or underreacts? What's their previous pain experience? A child who's had a lot of pain is going to be frightened of pain at a much lower level. What coping strategies do they have? Can they use TV to distract them, or their favorite movies, or their favorite game or book or crafts or whatever, or can they not? And so those are some of those non-pharmacologic things we want to do, but you can't say do crafts and then you have a kid who hates crafts. So you've got to make sure you're using what interests them. And that may not be enough. So we want to also do pharmacologic. So, again, some of those non-pharmacologic things: relaxation, distraction. This is going to be TV and movies and books and going to the playroom. Guided imagery. Can they imagine whatever, their favorite place, they're at Disneyland, whatever, massage. And then pharmacologic. Similar to adults, we're going to use analgesics. We use patient-controlled analgesia with kids. And just like adults, it can have a background rate that's continuous if we're expecting them to be in pain. They've just had a big surgery or something. It can do bolus dosing, so when they hit the button, it gives them a certain dose, or we can have both, so there's constant and then they can do extra. Local analgesia. If we're just starting an IV, we rarely do that because to put EMLA cream on, it takes about an hour. So now you have a child worrying that an IV is coming for an hour, which is probably more stressful to them than the poke of the IV. If we're doing a Metaport, which does hurt a lot and takes a lot of monkeying around sometimes to get it in the right, to actually access that port, we are going to do EMLA cream. So again, take into account the child. We can do epidural analgesia for things where that would give adequate pain control. Sometimes after like spinal surgeries, they'll come back with epidural running, and conscious sedation. Things like putting in PICC lines, they'll do conscious sedation. So our analgesics that we use non-opioids and opioids, and then anesthetics, sedatives, hypnotics, different levels of conscious sedation with each of those. So if we do opioids, just like your adults, we've got to really pay now attention to constipation, pruritus, right? A lot of people itch from morphine, and nausea and vomiting. It makes a lot of people nauseous. The one we're used to watching is the respiratory rate because that'll kill you, but you can feel pretty miserable from being constipated, itching, and nauseous. So we want to consider those as well. And when we do that conscious sedation on children, remember this is moderate sedation in a medically controlled state of depressed consciousness. So they're not totally under like anesthesia for surgery, but they're pretty loopy. And again, we'll do this for certain procedures, PICC lines being a common one. So you do want to ensure that there's emergency equipment available, that you're monitoring that airway, because everybody responds a little differently to medication, and maybe this child's going to go a little farther under than you meant for them to. So you need to be monitoring the airway and the child's level of consciousness and responsiveness. We expect them to be drowsy and kind of confused when we ask them things, but they shouldn't be where we can't arouse them at all. And then we're going to be monitoring their vital signs: heart rate, blood pressure, respiratory rate, and their oxygen saturations. So for pharmacologic management of pain, you're going to see opioids as well as non-opioids used. Those non-opioids include acetaminophen, which is Tylenol, and our NSAIDs, which are Motrin, ibuprofen is the generic name for that. The one you're going to see used a lot at Valley Children's is Ketorolac, and its brand name is Toradol. That is usually ordered around the clock for the first 24 to 48 hours after surgery. We expect this child to be in pain. This is a good medicine at preventing pain. If you treat mild pain with it, the pain won't get worse. If you wait till the pain's severe, it's not very effective at all. So it's not ordered PRN, not initially. And it's given just like an ordered medication. If you look this up, Ketorolac has a black box warning, and it says it should not be given for more than 5 days because of the risk of bleeding, right? All our NSAIDs have that anti-platelet aggregation effect, which is why we put people on low-dose aspirin. All the NSAIDs have that to different levels, but Ketorolac has it, which is why you should only use it short-term. And it's normally, at Valley Children's, the order will be either 24 or 48 hours. They usually order so many doses, but it's not more than 48 hours. So we're well below that black box warning. If we have somebody in moderate or severe pain, then we're going to use opioids. And the best one is morphine. That's what it's not the only one you can use, but that's the one you're going to see most often ordered, and particularly for PCA pumps. We also use fentanyl. You'll see that up in the ICU quite a bit. Codeine, hydromorphone, methadone is one you're going to see used particularly when we're weaning someone off of narcotics. If they were in the ICU and got a lot of narcotics, you do build up that physiologic dependence, which means you can't suddenly stop them. You will go through withdrawals. And we don't want these children doing that. We're trying to keep them comfortable. We don't want them now adding withdrawal symptoms on top of whatever is going on with them. So we use methadone most often for weaning. And the nice thing, it is a very long half-life. So we give it initially twice a day, and then we'll drop that to once a day, and then we'll cut that dose in half. So it weans them off of the narcotics that they became physically addicted to up in the ICUs. Oxycodone, the one you rarely see is meperidine, which is the brand name is Demerol, and the problem is that lowers the seizure threshold of the central nervous system. So a child will seize more easily, and it has a long half-life. So if they do have that side effect of seizing, they're going to keep seizing because it takes a long time for it to get out of their body. So that's one we don't use often at all in children. So the nurse's role in managing procedure pain. Think about a topical anesthetic, which is your EMLA cream, but remember that takes a good hour to work. Having a child stressed about pain coming for an hour may be appropriate, may not. It's going to depend on the level of the pain and the child. So use non-pharmacologic strategies. Talk to them about whatever you see around their room. They're wrestlers, if they have action figure wrestlers, or Star Wars, or Peppa Pig, or whatever you see. Prepare them for the procedure. The younger the child, the shorter time you prepare them. A toddler, you tell them immediately before you do it. An older child, you give them time to look at stuff and figure out what is going to happen. Positioning the child for that procedure. Consider therapeutic hugging, which means rather than pinning them down on the table, somebody's holding them, cuddling them with just the extremity that you need exposed. When we do something, use the smallest gauge needle that you need. You want it appropriate for what you're going to do, but go with the smallest that will meet your need. intermittent infusion devices or PICC lines, if we're doing a lot of blood sampling, those central lines we can draw off of, so that's always a nice thing for the kid. Just a side note, drawing off a central line requires a license. So the bedside nurses may not realize that, but that is not something a student legally is supposed to do. If you're needing quite a bit of blood from a baby, a venipuncture works better than a heel stick. Consider kangaroo care. There are studies that show that infants who get a lot of kangaroo care, skin to skin on mom, cry less for shorter. Their crying is not as intense, and it's a shorter time frame when we do painful procedures to them. And then non-nutritive sucking, which is the policy right here for Valley Children's. Non-nutritive sucking is to give a little bit of sugar, right? Sugar makes us all feel good. We like sweet treats. So there is a policy at Children's that you do not need a physician's order. You may do this as long as the infant is not intubated. If it's a preterm baby, they have to be over 1,400 grams. If it's term, 4 months or younger, so not more than 4 months. And what you do is you take those, it's a little thing, most people call them sweeties. It's the sugar water, and you can drip it straight into their mouth. You can put it onto a pacifier and let them suck the pacifier. And it makes them feel good. Peak effect is at 2 minutes, so the policy says that you give it 2 minutes before you do a painful procedure. You do it immediately again as you're starting the procedure, and you can do it one more time 2 minutes later. And again, studies show that it works. These babies, they cry when you poke them, but they don't cry as loud nor as long. So it is effective. And here's the EMLA cream. You do have to put that Tegaderm over it. It's not just to prevent it from getting smeared all over it. It actually is necessary in order for it to be active in causing that local anesthesia effect. So that's probably for a PICC line. And here's kangaroo care. And I love, if you notice, this baby is intubated. So we can do quite a bit. This baby is stable in a way, but not able to breathe without some help. There's a point where a baby's too unstable and we can't do this, but if it's possible, we want to get those babies into kangaroo care. Kangaroo care really is as effective as an isolate for keeping a baby warm, right? A baby's got to spend its calories either staying warm or growing. So we use the isolate or the warming table so they can spend their calories growing instead of staying warm. Well, body temperature is really good for keeping the baby warm. And then it's got just so many other bonding and nurturing pieces to it as well. And studies show these babies don't cry as much or as long if we get them into a lot of kangaroo care.